Once again, thank you to Danni Li, and we are going to start now. Thank you.
Well, thank you, Amy, and thank you everyone to be here for the grand round this morning. So my name is Danni Li, and I'm associate professor in our departments, and I've been here since 2012, so it's been 11 years. I'm also one of the clinical chemists that, in our department. So today that I'd like to tell you a little bit about my research and also the the significant research development in the areas of Alzheimer's disease. Yes, like Amy saying that, please feel free to ask questions if you have any, along the way. You can either speak up, or using chat box, and I'll try to monitor the chat box. And I wanted to have, I want this presentation to be as interactive as possible. Okay, so I have a few objectives. First, I like to review significant developments in Alzheimer's disease research, particularly blood-based biomarkers, and then I will switch gears, talk about our recent research findings of changing plasma lipidomics in early stages Alzheimer's disease, as well as what those changes inform us about Alzheimer's disease pathogenesis. So Alzheimer's disease is a neurodegenerative diseases that, the hallmarks of Alzheimer's disease are those extracellular amyloid plaques. And as the disease progresses, and there will be tau pathology that, as shown in this picture, the accumulation of neurofibrillary tangles intracellularly inside the neuron. And those pathology actually can take many, many years to develop in the brain without, causing obvious symptoms. At the later stage of Alzheimer's disease, that those patients will have very severe neurodegeneration, as illustrated by the significant shrinkage of their brain, and they also will have cognitive impairments, and then eventually that dementia. So Alzheimer's disease is really a public health priority. As it's estimated that one in 9 people aged 65 and older has actually Alzheimer's disease dementia. So Alzheimer's disease is actually a major cause of dementia worldwide. And it's projected that this trend is continue to grow over time. And by 2060, that it's estimated that 13.8 million of people in the United States will have Alzheimer's disease dementia. So this is really a public health, priority to come up with ways where we can, slow down, treat the disease and still slow down the, disease progression. So currently, Alzheimer's disease is actually diagnosed not based on any biomarker evidence yet. As I mentioned before, that there's this preclinical stage of Alzheimer's disease that pathology is being developing, but those people do not have symptoms. Clinically, most people with Alzheimer's disease are currently diagnosed in the stage of mild cognitive impairments or various stage of dementia. But clinically, biomarkers is not widely used to actually, to kind of characterize people yet. And this situation, we expect that is going to change because the recent FDA approval of anti-amyloid, immunotherapies that for Alzheimer's disease, particularly the approval of lecanemab, also known as Leqembi. So those to use those anti-amyloid immunotherapy, that it's required that those people that has abnormal brain amyloid deposition in the brain, and the way that those drugs works is that the anti-amyloid antibodies will cross blood-brain barriers and then will bind to fibrillary forms of amyloid, and then will trigger mediated microglia phagocytosis and therefore clear amyloid plaque. So recent data that published in New England Journal of Medicine for Leqembi has shown that a biweekly infusion of this antibody over 18 months of times that do lead to slow down progression of disease, as demonstrated in the figure where people on the treatment actually have slower decline in their cognitive function. So this is really exciting for Alzheimer's disease field and the patients, because now we have a very kind of, I wouldn't say very effective, but we do have ways now to actually treating Alzheimer's disease patients. So clinically, that there's two different ways we can detect brain amyloid deposition in the brain. So the first way is using amyloid PET scans with radioisotope tracers that targeting the brain amyloid. And then second way is actually by detecting soluble A-beta 42 peptides that in the CSF. So this is the data to show that those two ways of actually measure brain amyloid deposition correlate pretty well about 80% of the time. And so in people with positive amyloid deposition by the PET scan, as shown by the red triangle in this figure, they actually have decreased CSF soluble A-beta level. And so for people with negative amyloid by the PET scan, they actually have, increased level or normal level of A-beta 40, soluble A-beta 42. So but as you also can see that from this figure, there's about 20% of the people, those two ways of evaluating their brain amyloid deposition actually do not agree with each other. And this is likely because that the CSF soluble A-beta and amyloid PET scans, they actually measure different process of the amyloid beta aggregations. So the CSF soluble A-beta measure the soluble forms of A-beta, and it's related to not only CSF A-beta production, as well as the non-fibrillary forms of aggregation, such as the early, as we shown here, the oligomer formation, where the amyloid PET is actually measure more of the end product of the aggregation, such as the fibrils. So because of those differences, that those two ways of evaluation, even though they, correlate with each other most of the time, but they're not exactly the same. So now I'm going to switch gears and talk about blood-based biomarkers. So in the last 10 years or so, that the field of blood biomarkers for Alzheimer's disease has really prospered, and there's significant developments. due to the technologies that allow very ultrasensitive detection of the protein in body fluids. Single molecule array, also known as SIMOA, is one of the technology that really kind of pushed the field forward. So this technology is really very innovative, and then so it's based on two principles that eventually allow very ultra-sensitive detection of protein. First, is that compared to the traditional ELISA, which used for detections of proteins, this SIMOA technology that really miniature all the wells into the size of less than 10 micron. So as you can see this picture, see that each of those magnetic particles actually is each of those wells that can only hold one of those magnetic particles. And this will, therefore, that it allows really concentrated detection of the fluorescent signal. The second aspect of this technology is allowing ultrasensitive detection is that instead of measure analog signal, they actually digitize the signal in such way that the concentration is no longer depending on the analog intensity, but on yes or no readout of each those individual micro well. So as a result of those inventions, that as you can see, the technology that can actually measure protein concentration at 1,000 times lower the traditional ELISA. So around that time, a group that was able to actually publish data to demonstrate that by measuring plasma A-beta 42, and it gives actually similar performance as the CSF A-beta, soluble A-beta 42. So this is showing that how those two different biomarker tests, that their performance across 4 different diagnostic groups. On the right hand side is the CSF A-beta 42/40 ratio across controls, people with subjective cognitive decline, MCI, and AD. And you can see that this downward trend, and then also the same trend is seen that when you measure the plasma A-beta 42/40 ratio. The difference, though, is that the magnitude of change across the groups is much bigger when you measure CSF A-beta 42/40 ratio than the plasma. So over the last 10 years, then, kind of driven by those very innovative technology, and there's now more than one plasma A-beta 42/40 ratio test or assays available, but not all of them actually have the same performance. So this is a study that published recently that kind of conducted a head-to-head comparison of many of the plasma A-beta 42/40 ratio assays that are available in the research space. And so here are 5 different assays that 2 of them are based on mass spectrometry, and 3 of them are based on immunoassays. So as you can see that the AUC curve for those 5 assays that are not identical, the one that has the best performance is the one that by Washington University based on immunoprecipitation mass spectrometry. And this assay has an excellent performance compared to gold standard, which are the amyloid PET or CSF A-beta 42/40 ratio. And also that if you look at how those plasma assay results correlate with CSF results, you can see that this Washington University assay actually has the best correlation with the CSF, suggesting that the specificity of those plasma assay in terms of towards this, CSF A beta 40 ratio is the driving factors of their performance. So now we have many different fluid biomarkers and neuroimaging biomarkers that we can use to evaluating and characterize people with Alzheimer's disease. As I mentioned before that, about using the CSF A beta 42 and plasma A beta 42 to help actually detect people with abnormal amyloid. And then also we discussed about amyloid PET and then so another biomarker that has been very popular in the research space for Alzheimer's disease is phosphorylated tau. And so using phosphorylated tau, that we can actually detect the increased phosphorylation and secretion of soluble tau. And then also another one is neurofilament light, which is a biomarker for neurodegeneration. And so and using this, that we can actually detect later stage Alzheimer's disease where there are accelerated neurodegeneration. So here is the slide kind of also summarized some of the different isoforms of plasma p-tau and their performance. So on the left-hand side, so there's actually currently there are 3 different p-tau isoforms that are popular, and 181, 217, and 231. So on the left-hand side, it compares the different p-tau assay and how it can detect people with and without brain amyloid deposition among older adults with MCI. So as you can see that the best performance is actually the p-tau assay, p-tau 217 assay by Washington University. It's also based on mass spectrometry. And then in addition that those p-tau assays really good with detecting people progress in terms of their Alzheimer's disease, for example, from MCI stage to dementia stage. Again, the p-tau 217 assay performed the best. So right now, there's a lot of hope actually to actually bring this p-tau 217 assay that to the clinical lab to use to help diagnose people with Alzheimer's disease deposition, as well as predicting future disease progression. So here the field has also progressed in terms of coming up with biomarkers for other neurodegenerative diseases. So there's also now RT-QuIC assays to measure alpha-synuclein aggregation. And then there's also CSF biomarkers such as neurogranin to measure post-synaptic degeneration, as well as assays for SNAP25 GAP43 for presynaptic neurodegeneration, and then also by measuring CSF and plasma GFAP, which is a biomarker for reactive astrocytes, and as well as the CSF PDGFR beta, which is a biomarker for capillary parasites. So to summarize this part of my talk, and so first we discussed about the recent FDA approval of anti-amyloid immunotherapy which requires detection of abnormal brain amyloid deposition in the brain. And then clinically, amyloid PET and soluble CSF A beta are clinically available for detection of brain amyloid. And then there's significant potential of using blood-based biomarker for screening of Alzheimer's disease. The caveat is that those blood biomarker are less specific, however, that they're also less invasive. So, and then we also talk about biomarker that beyond Alzheimer's disease for other different neurodegenerative diseases. So now I wanted to kind of switch gear and talk about lipids and Alzheimer's disease. So lipids that play a very important role in pathogenesis of Alzheimer's disease. So many of those genetic risk factors for Alzheimer's disease involved in lipid trafficking, lipid synthesis, and lipid sensing, such as the most kind of significant risk factor for Alzheimer's disease, ApoE4, is actually lipid transporter proteins, and also TREM2 is a lipid sensing transmembrane receptors that on microglia cells. In addition to those genetic risk factors, now it's well known that Alzheimer's disease has other comorbidities such as diabetes and hypertension. So those comorbidities actually increase the risk of people developing Alzheimer's disease, and those disorders that has also associated with peripheral lipidomics changes. And so the idea is that those peripheral lipids and metabolite changes can also modify the disease risk of Alzheimer's disease. So the question that my lab has been very interested in last several years is the changes in plasma lipids and how that can inform us about Alzheimer's disease pathogenesis. So I started this research directions in about several years ago. We actually looked into plasma phospholipids and the prevalence of MCI and dementia in ERIC neurocognitive study. And recently that we then take a slightly different approach, and we turn to ADNI, which is Alzheimer's disease neuroimaging initiatives. So this is a longitudinal study of fluids and imaging biomarker for Alzheimer's disease. And the nice thing about ADNI is that all the data is available publicly. So we turn to ADNI to ask the question is, what are the plasma lipidomics change that across Alzheimer's disease that defined by biomarkers? So particularly we included ADNI participants without dementia. We focused on people with plasma lipidomics data, as well as certain CSF biomarker and neuroimaging data. So we then the next thing that we did is that we actually defined stages of Alzheimer's disease by the available biomarkers in ADNI. So we first actually defined control and stage 1 and stage 2 by their negative tau pathology. In this case, that we used p-tau or total tau levels that in CSF as the definition of tau pathology. And then we further actually stratify the people with negative tau pathology into control stage 1 CSF first and stage 1 PET first and stage 2 by their combination of amyloid PET results and CSF soluble A beta results. So control are defined by negative amyloid pathology by both amyloid PET and CSF. And stage 1 is actually CSF first is defined by people with negative amyloid PETs but positive by CSF soluble A beta. And then stage 1 PET first is actually defined by people with PET first, by positive PET but negative soluble beta. The reason why we kind of put those two kind of subcategories is that there's literature suggests those are different mechanisms, and therefore that I think we were really interested in whether there's an indifference in plasma lipids, in those two group of people. And then also for stage 2, we define them by positive amyloid pathology by both amyloid PET and CSF. So, and then we define later stage by positive CSF, p-tau, or total tau level. And then for stage 2.5, we define them as positive amyloid PET, negative CSF. And then stage 3 is positive by both amyloid evaluation. And also, it's interesting that there's people actually have what they call SNAP, which is stand for suspected non-AD pathology. In those people, they have positive p-tau or total tau in CSF, but they actually have negative AD pathology. So this is the schema that we came up with to define Alzheimer's disease stage in this project. And so then the next thing that we did is that we kind of looked into the demographic differences across those different stages. And indeed that we found, stage 1 CSF and PET first, actually those people are have like a younger age than the later stage. And also we see that as people progress to a later stage of Alzheimer's disease, that there's higher proportion of people with mild cognitive impairments. And then also, between the two early stages of Alzheimer's disease, CSF first versus PET first, we see some very interesting difference in this, percentage of, kind of sex distribution, particularly that in the CSF first group that we see a higher proportion of male. And then also we see the difference that in terms of number of people with ApoE4 allele across those two conditions. In particularly, we see that in people in the PET first stage that actually they have less people with ApoE4 allele. So those are the interesting observations suggesting us, again, that those maybe two stages could be, biologically different. So the next question we looked into is how the plasma lipids change across those 80 stages that we defined. And we actually see a pretty consistent pattern in our data where the stage 1 CSF first, there's actually significant decrease in plasma lipids, where that in the stage 1 PET first, then we see the increase of those lipids. So what does this tell us about what's happening in the brain? So in order to answer this next questions that we looked into TREM2. So as I mentioned earlier, that TREM2 is a lipid sensing receptor on microglia. And so its job is to sense the lipid changes in the brain microenvironment and then responds to those changes and then limiting A beta accumulation neuronal loss. So, and also TREM2 actually undergo regulated proteolytic cleavage, so that we can actually use the CSF soluble TREM2 level actually to monitor the microglia activation. So there has been also data that in animal models showing that CSF soluble TREM2 is protective in terms of AD pathology. And then in human data, it's shown that higher CSF soluble TREM2 level is associated with slower accumulation of tau pathology. So we then looked into how the CSF soluble TREM2 level changed across the early stage of Alzheimer's disease, early stages of AD. And what we found is that during the stage 1, there's actually significant decrease. Stage 1 CSF first, there's significant decrease of soluble TREM2, where in the stage 1 PET first, there's significant increase in the CSF soluble TREM2. So combining this data with what we are seeing in the plasma lipidomics change, it's suggesting to us that during those early stage of Alzheimer's disease, there's brain lipidomics change happening in the brain as reflected by those by this distinctive change pattern of CSF soluble TREM2, and then those plasma changes is reflective of what's happening in the brain.
Danni, quickly, please. Can you go back?
Yeah.
So what's stage 2 again?
Oh, I'm sorry. Is this the page or go back?
Yeah, this page.
Okay.
I forget what's the stage 2 is CSF and PET.
Yes,
right?
stage 2 is positive by both CSF and PET. Yes.
Okay, so we don't know that this is a longitudinal change from.
Yeah. No, it's
Okay.
Yeah, this is cross-sectional. Yeah.
Okay.
Mm-hmm. Yeah, but it's interesting that, in the stage 2, it's, I think my hypothesis, if you look at this stage 2, it's because it's a combination of, in people with stage 2, you have both CSF and PET abnormal, and those pathology has opposite effect on the CSF soluble TREM2. That's why I think the stage 2, the level is actually kind of in the middle, compared to the CSF first and PET first. So, thanks for the question. All right, so next, so we were really intrigued by this finding and the difference between those early stages that so the next thing that we did is that we actually look into the association of CSF soluble TREM2 and the plasma lipids. We just using a linear regression model to kind of model their association across different AD stages. And what we found is interesting that during the stage 1, CSF first, there's significant correlation of CSF soluble TREM2 with plasma deoxyceramides. And also we don't see this correlation in the other stage of Alzheimer's disease. So what is deoxyceramides? Well, deoxyceramides is actually different from ceramides by owning one hydroxy group. And it's believed that deoxyceramides is synthesized, instead of using serum, it's alanine. So there's a different amino acid is used to actually synthesize deoxyceramide compared to ceramides. So the next thing that what we did is then we kind of look into how the plasma lipids in general correlating with plasma lipoproteins. So what you see here is a heat map. In each row is a plasma lipids that measured in the unfractionated plasma, where in each column is, it's the lipoprotein, different lipoprotein, and then the lipid composition, within them. So interestingly, that what we've seen is that the deoxyceramides is highly correlated with VLDL. And this is in contrast with ceramides, where ceramides actually is strongly correlated with non-HDL particles. So this kind of prompts us to then further looking into VLDL and then the relationship with CSF soluble TREM2. So interestingly, what we found is that the lipid composition of extra large size of VLDL in plasma is actually strongly correlated with CSF soluble TREM2 level. In particularly, as those VLDL, has more, cholesterol, they actually associate with a lower level of CSF soluble TREM2 in the stage 1 CSF first stage. So so putting those together, how do we explain, this data that we've seen? So we kind of looked into literature, and what we found is that actually there's strong evidence to support that VLDL, peripheral VLDL, is playing an important role in clearance of cerebral amyloid beta. So what we think that what our data explain to us is that the accumulation of cholesterol in VLDL is actually decrease the clearance of cerebral amyloid beta and increase the aggregation, and then which is then leading to actually decreased level of CSF soluble TREM2. So then the next thing that we further looked into is also what are the other lipids in the plasma associated with CSF soluble TREM2, and what we found is the plasma acylcarnitine. So acylcarnitine is part of the carnitine system that help transport fatty acids into mitochondria for oxidative phosphorylation. So this correlation actually suggests us that the role of mitochondria. So again, I was kind of trying to figure out that what does this data means, and so how is the mitochondria is linked to cholesterol accumulation in VLDL? So fortunately, that I was able to actually found there was a recent publication in Cell that describing how the mitochondria and RUF-ER contact is actually regulating the VLDL synthesis in hepatocytes. So I think what this data is kind of suggesting to us that the dysfunction in mitochondria, in particularly in the wrapper ER mitochondria contact, is leading to is basically leading to kind of dysregulation of VLDL synthesis, and then that is impacting how VLDL is clearing cerebral amyloid beta, and therefore leading to the decrease of CSF soluble TREM2. So I think I'm very excited about this connection, and then also recently there's another paper actually published just in Neuron that's suggesting this connection between liver and Alzheimer's disease. So what this paper shown is that hepatic soluble epoxide hydrolase which is a enzyme that modulates plasma 14, 15 EET level. And this is a plasma omega-3 fatty acid that can actually readily be absorbed by the brain. And so how this actually plasma level is regulating the cerebral A-beta metabolism. So the disbalance between those, the 14, 15 EET and A-beta leading to A-beta plaque and AD pathology. So this is, again, this is a very exciting evidence that really kind of supporting what we are seeing is the connection between liver, particularly liver enzyme regulation of omega-3 fatty acids, and how that is actually related to Alzheimer's disease pathogenesis. So with that, I like to just summarize this part of the talk, that lipids playing very important role in pathogenesis of Alzheimer's disease. And we have, through our investigation, we've seen changes of plasma lipid over stages of Alzheimer's disease that really help us provide some of the insight. And also, we think that peripheral organ change during aging that really can contribute to Alzheimer's disease pathogenesis. So in terms of future direction, I'm very excited because recently we have received 2 R01s that actually to study lipids and mitochondria and lipoproteins. So this research finding is really kind of, again, confirm that those research directions that we're heading into. And also, I'm very interested about the differences in early stage of Alzheimer's disease, particularly the CSF first and PET first pathways. So we hope that we'll be able to, look into some of those protein differences in CSF, neuroimaging outcomes, etc., to really trying to understand, are those different stages of Alzheimer's disease or not? So with that, I like to thank the people who contributed this work, and particularly Lu Meng, who is actually an undergraduate student who did a lot of those data analysis I'm showing you today, and also my collaborator and funding. Thank you for your attention.
Hey, Delhi, go ahead.
Yeah, thank you very much, Danny. I really enjoyed that. So quick question. What do you think is responsible for the gender differences in the CSF force versus PET force? Because I think that's quite interesting. So have you looked at the influence of hormones, either the influence of hormones on the lipids or independent of what is going on at the lipid level?
Yeah, that's a really good question. We haven't looked into hormones, but I do think that's potentially play a role in lipids. And yeah, so I do think that that would be a very interesting investigation to look at the hormonal difference. Yeah, and I think I'm not sure Annie has the data, but that if they do have data, that would be very interesting. We also see, yeah, those lipids, some of them, I mean, I haven't shown it, but there's a lot of difference in sex as well as ApoE4. Sometimes it's hard to, figure it out, but we've seen, yeah, sex differences.
Dr. Yogi.
Yes.
Yeah, hi, Danny. Interesting talk. I was just curious with the association with the liver and lipid metabolism. Is there any association with NASH, non-alcoholic steatohepatitis, and Alzheimer's?
Yeah, that's an excellent question. I've been wondering about that. So I don't know. Actually, I haven't looked into it, but I think that's an excellent question.
Dr. Singh.
Hi, thank you, Danny. That was a really good presentation. I was actually very interested in what you said at the end, that we kind of need to study more about the two pathways, because right now I think we are only looking at them biochemically, the two, the CSF first and the PET first. So I just wanted to know from you, like at this stage, do we have any clinical differences? Like, do these two different stages that you've mentioned biochemically, how do they translate to the clinical?
Yeah, that's an excellent question. So this is actually a question we currently actively look into. We actually at this moment I have a student that look into whether, for example, there's differences in disease progression in those two groups of people. So we hope that we'll be able to have some answer soon.
Thank you. Thank you.
Hi, Andrew.
Hey, Danny, thanks. Great talk. This is kind of an out there question, but I want to see if I can get some insight from your expertise. Both of the pathways that you're studying in relation to Alzheimer's pathogenesis obviously can be related to altered immune function and regulation. And given the drugs and the excitement about the drugs and also the controversy about the cost of the drugs, I'm wondering, thinking about biomarkers, not only for making an accurate diagnosis of true underlying Alzheimer's pathology like you presented, but do you think that there's going to be a role for understanding the immune reaction in the Alzheimer's pathology to predict who might get the most benefit of the drugs? I'm of course thinking from our roles in cancer, where it's not only the type of cancer and ensuring that we have the right type of cancer, but assuring that the nuances of the pathology in that cancer are actually having the right interaction with the immune system in order for some of our drugs to work. So I'm wondering along that line what your thoughts are, since you know way more about this than any of us.
I think you think way ahead of the field of Alzheimer's disease current thinking, but I think this is like you're saying, you come from cancer field, and that's kind of already what people are doing, right? I would say in Alzheimer's disease, I'm not aware people like thinking about ahead and thinking about using kind of immuno function and et cetera to further stratify people, who is going to respond better. But I think that's a great idea. I mean, and that's where exactly the precision medicine is important, right? So I do think that would be a really kind of cool project.
Thank you. And like I said, I mean, understanding more about the pathways that you're studying and interested in your R1s or function, I think we'll dovetail into that nicely. So it'll be cool to see how that goes.
Yeah.
Yeah.
Okay, Dr. Ahmed is next.
Excellent talk. I was curious, does HDL have any correlation at all, positive or particular with the development of AD?
Yeah, you nailed it. So honestly, we have done a lot of investigation of HDL. I don't have time to show it. In fact, at my lab, the work that we do actually focus mostly on HDL instead of VLDL. I think it is different, and I think that I don't know. I feel like HDL maybe not play a huge role in necessarily just the A beta clearance per se, but I think there's my suspicion is that HDL mostly has a lot of actually good quality in maintaining the blood-brain barrier function. So I think yes, you're absolutely right that HDL is also very important, and we have actually data to suggesting that as well.
Thank you.
Yeah.
And Delhi is up next again.
Yeah, just a quick comment to Sophia's point on NASH and things. I just wonder if you think that using autopsy material will be useful in this context, because there are years of brain tissue and there are years of liver from the same patients. You might not be able to have access to the CSF and the PET data. Maybe some of them even have PET data. just something to think about when you are thinking of moving out of the mouse model.
Mm-hmm.
Okay.
Yeah. I think the idea of having access to those tissue and kind of looking to it would be great. Yeah, we are working using tissues from mouse model, but I think it's always to have human tissue to kind of confirm what we are seeing in the mice.
Yeah, if you touch base with Emil, I'm sure that he might be able to tell you what's available or not.
Okay, great. I'll reach out to you.
Okay.
And Zoe is next.
Hi, good morning, Dr. Li. That's a great talk. Mine will be more of a basic question in this sense. So have you guys looked at the lipid profile oxidation state, since typically Alzheimer's disease, you have a high oxidative stress, and if that impacts the lipid profile, creating like free radicals on these lipids, and how does that impact the clearing?
Yeah, so that's an excellent question. Obviously, there's a lot of interesting ROS lipid oxidation. So I think there's a lot of evidence too to support that. We haven't actually looking at ourselves, but that would be really interesting to look into lipid kind of oxidation of lipids and how it's associated with Alzheimer's disease. Yeah, especially in the early stage. Yeah.
Jesse.
Thanks, Danny. So I have a question about your lipid experiment that you did where you had the different groups of lipids. How did you set that up, and how did you control for batch effects? So I've been involved in like CKD Biocon, and I've seen these batch effect type things that can trick you. And did you intersperse the different subgroups into each other, or were they all kind of separated?
Yeah, so you brought a really good technical question, right? So, just with, all biochemical analysis, whether it's ELISA, whether it's by mass spec and proteomics, lipidomics, that batch effect is always potential confounders. So I would say, in my experience, that we are trying to including a lot of, kind of checks and balance to make sure that we have ways to, understand whether batch effect, whether it's happening. And then if so, that how do we actually can, kind of quote unquote normalize it. Mm-hmm. So we usually with those lipidomics, we definitely, as there's internal standards, you spike into the sample, and then there's also, let's say every 10, 15 sample, you'll also have a pooled sample that is representative of your, kind of entire study sample. So, I mean, there's things, and also you want to probably make sure that, for example, if you're doing case control study, you want to make sure, within each batch, you have, a equal amount of case and control, so that ultimately, if there's potential batch effect affecting your sample or experiment condition equally. So I think it is something that have to deal with, but I think there's ways that can mitigate it.
Okay, and you didn't see any batch effects across that study?
So the data that I'm presenting today is from ADNI. So those are the data that they already kind of, evaluated batch effect. And so I don't really have any insight on that, but I was more speaking about, some of the data that we have from my own lab in terms of proteomics and lipidomics. So.
And then one other question too, with regard to like the mass spec approach for the amyloid plaques. Do you think that's because, I'm guessing that they're using digestive approaches in these in the proteomic, or is it intact?
Yeah, there. I would say most of the study that I'm aware of, there is kind of the shotgun approach, where they,
for digesting.
Yeah.
Do you think that's because, like, let's say you have a bigger fibril or whatever, and you're able to digest that with the enzyme, as opposed to the antibody can just recognize the a fixed volume of surface? I mean, what's the reasoning why mass spec is more specific is what I'm trying to get at. I don't understand why it would be more specific than like the immunoassay, like the Simoa technology?
Oh, okay. I guess so. I wouldn't. Okay. Oh, you were talking about the like
You showed the raw curve where the mass spec
yeah.
method, right?
So you know, immunoassay is hard. I mean, it really kind of depends on the quality of the antibodies, right? So I don't really know, but I feel like, with immunoprecipitation followed by mass spectrometry, you probably have a higher specificity than just using immunoassay alone. That is kind of my and I guess my guess. But also, I mean, those IPMS methods actually is very label intensive and requires
Right.
like
Yeah.
a lot of
That's what I was thinking too. I was like, that'd be a nightmare to kind of implement.
Yeah, I mean, it's probably, I mean, it's no doubt that they performs better, but it's probably not going to be kind of widely available, especially for screening of Alzheimer's, kind of screening for brain amyloid. So
Okay.
Yeah.
I thank you.
Yeah.
That looks like we are done. Thank you very much for an excellent presentation.
Yeah, thank you, everyone.
And we will see you again next Wednesday. Thank you.
Yeah.
Recording stop.